We will learn the inherited ichthyoses, the syndromic forms, which are of these different types, and they are pathophysiologically divided into two, the bricks and motor. So the ones which affect the bricks, which include the keratinocytes, the conified envelope, or the proteases, the inhibitors, and the motor, which is the intercellular lipid between these bricks. So that includes the lipid biosynthesis cholesterol ceramide. The kallikrein are the proteases which are responsible for desquamation. So in case there is defect in LEKT, so it will not be it it LEKT inhibits it. So if there is mutation in this which happens in Netherton syndrome, it would lead to more desquamation. If there is matriptase deficiency, so kallikrein won't be able to work, so there will be retention. So the first syndrome is Netherton syndrome, where we have discussed the pathophysiology of excess desquamation. It is characterized by prominent hair abnormalities, in which we will discuss about Netherton, ichthyoses hypotrichosis syndrome, and ichthyoses hypotrichosis sclerosing cholangitis syndrome. Netherton pathophysiology we have already discussed. Its phenotype includes three special features, which are ichthysis linearis circumflexa, CIE-like trichonexis invaginata, and atopic dermatitis, characterized by bamboo hair. And systemic markers are for increased IgE and atopic and neonatal life-threatening dehydration. Then this is showing bamboo hair. This is showing ILC. Then the second hair one was hypotrichosis syndrome due to matriptase, so retention of the scales, and it is characterized by this loss of eyebrows, eyelashes initially, and then receding frontal hairline. It presents as lamellar ichthysis and as pili torti or pili bifurcata hair. Then sclerosing cholangitis, it is due to defective cell junctions, and the phenotype has jaundice and hepatomegaly. Then moving on to the prominent neurological signs and ichthyoses, which are autosomal recessive. Their pathophysiology is the defect in intercellular lipid processing, the motor. So first one is Sjogren-Larsen syndrome. So it has two dots, which is perifoveal glistening white dots, and it has deficient fatty acid aldehyde dehydrogenase because of the defective gene aldehyde ALDH3A2. It is characterized by fine plate-like dark scaling over the neck, abdomen, and flexures, severe pruritus like in case of Netherton, which had AD, flexural hyperkeratosis, and the CNS features include spastic diaplegia, paraplegia by the second year of life. The second one is trichothiodystrophy, which we can learn by the mnemonic PBIDS, photosensitivity, brittle hair, which is like this trichoschisis or the this pattern, and intellectual disability, ichthyosis, developmental delay, and short stature. Then another one with neurological abnormality includes Refsum syndrome, which has deficient phytanyl CoA hydroxylase, leading to buildup of this due to defective paroxysmal hydroxylation due to these two genes, which is PHYH and PEX7. Cutaneous feature, it is characterized by ichthysis vulgaris like marked hyperkeratosis at olecranon and patella, and its mnemonic is NARD, which is neuritis, ataxia, retinitis pigmentosa, and deafness. Then neutral lipid storage disease, which is also known as Chanarin-Dorfman syndrome. It is due to deficient or altered triglyceride metabolism due to gene ABHD5. And the pathogenomic test is the Jordan abnormality, which is the lipid vacuoles in eosinophils and monocytes. It is characterized by generalized white fine scales on a background of varying erythema. Then we move on to the third category, which is X-linked diseases. X-linked dominant ones are the congenital hemidysplasia with ichthyosiform erythroderma and limb defects child syndrome. So X-linked dominant ones will be fatal in male and they'll present in females. And ichthysis follicularis alopecia photophobia, this is X-linked recessive, so it will not manifest in females but be seen in males. Then child syndrome is strictly unilateral, ipsilateral limb defects, stippled epiphyses, amelia, hypoplasia of digits, and it is due to disruption of 3-beta hydroxysteroid dehydrogenase. All of these are due to cholesterol biosynthesis defect and it interferes with the sonic Nichmark pathway. Conradi, so it will present as this half hemi ichthyosiform erythroderma and ipsilateral limb defects, unilateral inflammatory epidermal nevus, limb defects, and hair and nail abnormalities. The Conradi-Heunermann-Happel syndrome is just like child and it is segmental or along the mosaic lines. And erythema resolves initially, unlike child syndrome, and it has chondrodysplasia punctata associated. So this has this flashcoid pattern. Then moving on to the fourth category, which is the syndromes with prominent deafness, which is KID syndrome. It is due to GJB mutation in connexin 26, autosomal dominant, and it is characterized by porcupine-like hysterics or cobblestone hyperkeratosis, leathery skin, perioral furrows, and reticulate PPK. Extracutaneous features include SNHL, deafness, keratitis, and conjunctivitis. There are some syndromes which can present with respiratory distress, which is ichthysis prematurity syndrome, which is transient in nature.